Thanks to modern advances, an HIV diagnosis is highly manageable. Provided the virus is detected early, people living with it can expect a normal lifespan. The primary challenge in catching it early is how the virus behaves in the body right after infection. Stage 1, known as acute illness, mimics a routine bug. This initial ambush usually kicks in about 2 to 4 weeks after exposure. Patients frequently experience a sudden fever and intense night sweats. This happens because the immune system recognizes an invader and raises the body's internal temperature, attempting to kill off the virus. While that's happening, the virus travels rapidly through the lymph fluid. In response, white blood cells mount a defense, leading to noticeably swollen lymph nodes in the neck, armpits, or groin. 90% develop a macular rash, flat reddish bumps on the torso, prostate inflammation in affected men, or distinct penile ulcers. Eventually, the immune system stabilizes, and these physical symptoms completely vanish. This creates a false sense of security, convincing the host they simply fought off a minor infection, while the virus actually entrenches itself. That disappearance marks the transition into Stage 2, asymptomatic HIV infection. A person in this phase will look and feel completely fine, sometimes for up to 10 years. This chart shows exactly what is happening beneath that clinical latency. The first line indicates the viral load is steadily increasing over time. Simultaneously, the second line shows the virus silently destroying its primary target, CD4 white blood cells. Even without a physical symptom, the virus is highly active. The host remains infectious, easily transmitting the virus to partners without realizing they carry it. Because the body gives off no physical warning signs during this multi-year phase, proactive medical testing is the only way to identify the threat before the immune system sustains irreversible damage. But there is a biological catch to getting tested. You cannot accurately detect the virus immediately after exposure because of what is known as the window period. This timeline graph maps out seroconversion. Day 0 represents exposure. Notice the spike in P24 antigens and antibodies doesn't occur until weeks later. For a fourth-generation laboratory test, clinics need a minimum 45-day window post-exposure. At that 45-day marker, the test accurately catches the spike with 99% certainty. Rapid point-of-care or at-home self-tests rely on different mechanisms. To guarantee accurate results with these tools, the timeline must extend to a full 90-day window. Navigating these window periods is the first step toward intervention. If a test is taken too early, a false negative allows the viral multiplication to continue undetected. When testing is timed correctly, the virus can be caught and stopped. It never progresses to Stage 3, where the immune system breaks down entirely and opportunistic infections take over. The medical intervention used to halt this timeline is called antiretroviral therapy, or ART. ART medication specifically blocks the virus from replicating. By cutting off that multiplication process, the body gets a chance to preserve and rebuild its remaining immune function. This chart shows the medical outcome of regular treatment. The viral load drops to a baseline of 0 transmission risk, while the rebounding line indicates that the immune system's CD4 cells are recovering. Medicine can also intervene outside of this infection timeline entirely. Tools like PrEP and PEP can be taken either before a potential exposure or immediately after, neutralizing the virus before an infection even takes root. Mapping out the symptom timeline and navigating the testing windows turns HIV into a highly manageable condition. With the right tools and timing, individuals can break the cycle of transmission and live long, healthy lives.